The past 15 months have made most of us in the U.S. think about healthcare more than ever before. But here in the Adirondacks, healthcare has been an issue of paramount importance for decades. Where one goes for a physical for their child to a major medical procedure requires planning and flexibility every day. It's also something that our guests this evening have devoted themselves to, providing healthcare to those in the North Country for 40 years. I am so pleased to introduce this evening's speakers. Dr. John Rugge is a family physician. He is the founding CEO and now executive chairman of the Hudson Headwaters Health Network. He has served as a health policy advisor in both Albany and Washington, D.C. throughout his career. Dr. Tucker Slingerland is the current CEO of Hudson Headwaters. He is a family physician who joined the network in 2008 and has been deeply involved in Hudson Headwaters' transformation to the patient-centered medical home model. In conversation with our two physicians this evening is Thom Hallock of Mountain Lake Public Broadcasting. And I will now turn it over to Thom.
Thank you very much, Cheryl. We appreciate it. We thought we would begin with numbers, by the numbers. We see that so many places, and if you look behind us, you're going to see some very impressive numbers. 21 health centers now, 72,000 square miles across upstate New York, 1,200 patients cared for each day, 1,200 plus, 97,000 patients cared for in 2020, $871,325 spent in charitable care, 425,000 plus patient visits in 2020. A network made up of 88 physicians, 102 physician assistants, nurse practitioners, nurse midwives, dentists, licensed clinical social workers, 259 nurses, 906 total staff members across the Adirondacks. Many of them are friends and neighbors. And those are some impressive numbers that for 40 years have made up Hudson Headwaters Health Network, and we are so happy to be joined by Dr. Rugge and Dr. Slingerland tonight to talk about it. Gentlemen, welcome.
Thank you.
The name of tonight's speech and presentation is called From House Calls to Mobile Health, What the Adirondacks Can Teach Us About the Future of Rural Healthcare. And we are going to begin it and get to question number one, and we have several questions that we'll be asking the doctors, and then we'll be opening it up to your questions in just a little while. We'll be going about an hour for tonight, so let's begin with the questions for the doctors. For those who are not familiar, what is Hudson Headwaters Health Network, and how did it come to be? Explain a little bit, if you would, about the region that Hudson Headwaters Health Network serves, its rural nature, the geographic area, the economic and demographics, but tell us about the beginning. How did this come to be?
Here we go. So this summer, the town of Chester had three physicians, two were long planning their retirement, are married to one another. The third was a 42-year-old physician, so the town and the community had no worry, except that summer all three physicians departed, left the area. And the town supervisor organized a search committee, which in turn advertised and made pleased, and had basically one responsible physician out of the area saying he would be interested in coming, but he would want a free coffee pot. And the search committee said, what? The physician wants a coffee pot for free? We can't consider this. With no other applicants, turned out to go down to Glens Falls Hospital and say, we're in trouble. We just are about to lose all the medical care. And if you lose the medical care, you lose the pharmacy, you lose people buying their gasoline locally and doing their shopping locally. We need help. The hospital at that point was doing well financially, and so as a throwaway, sure, we'll give this a try. And instead of a coffee pot, the town purchased the home office of the senior physicians who were leaving, the couple who were leaving, with the arrangement being that at the end of the year, the hospital doing the operations will calculate the profits, pay out of the profits the cost of the mortgage, and then divide the rest 50-50. there was a problem. There were no profits. It was only red by way of ink. And so the question is, what to do? The town felt the need and wanted to continue support. But unexpected things happened. There turned out to be a deficit of some $16,000 in the town. Boy, yikes, what do we do with this? Ladies in the community came together and decided we will form a guild, a hospital guild. And each one contributed recipes and made a cookbook. And so if you went to the hardware store or were buying your hammer, you'd be offered a cookbook. Grocery store, health center. And on that basis, we continued limping along until about a year later, Dr. Lawrence in Lawrenceburg announced he was having a meeting of area physicians, 8 physicians from all the neighboring towns, and at that meeting indicated he had it. He'd been seeing patients until 1 in the morning and just couldn't do it anymore. Would be retiring from practice, hoping the rest of us could fill the void. So, the hospital decided we would give this a venture too, and try to make up in volume the deficit that was being accumulated. You can imagine what happened. On a per encounter basis, a per patient basis, it was better, but the overall cost only increased, the overall deficit. Then came North Creek and Indian Lake. So we had the Chester Health Center, the Lawrenceburg Health Center, the North Creek Health Center, and the Lawrenceburg Health Center. And in August of 1978, I got a phone call between patients, and a lady who said she had just moved from Kentucky because her husband had a new job, and in Kentucky she'd been writing grants and thought there was an opportunity in healthcare because in 3 weeks a deadline for the community health center program was coming. What did I know about community health centers? And my response was, I never heard of that. What's that? But it turns out, and this was a program that had been started actually in Mississippi and in Boston in 1965 and was grant supported through the Great Society initiatives. And was just beginning to be in the test basis about whether this would be a more long-standing program. And so in the course of 3 weeks, we wrote an application and we're pleased to receive notice a few months later that we were approved, but not funded. There wasn't enough money to fund us. In the meantime, the state had issued a similar kind of request. We applied for that by polishing off the first request and revising it a little bit, and that came through that year. And so at a time when I had a slip of paper on my desk requested by the hospital to close the Chester Health Center because we couldn't afford all this, we eked it out with this combination of local support that continued and continued and continued, matched by Concern in Albany, in part because people there were so impressed by these little towns that didn't have much, providing our buildings, paying for the heat and lights, in some cases paying for our janitor. And on the strength of that, we had the start. Actually, we thought that was the finish. Now we had it accept. A requirement of this grant was we could no longer be part of the hospital. We no longer had the security of a larger institution able to make any deficit up. And so 40 years ago, we had to go independent and create Hudson Headwaters Health Network, Inc. We never used the Inc. And in fact, at that time, my conjecture was nobody would know what Hudson Headwaters is. They'd know they were at the Chester Health Center, or the North Creek Health Center. Hudson Headwaters was just something for grants, for this grant. But it turns out, over time, there was an expanding need. A need caused largely by something we just saw in the museum here, the Adirondack Experience, World War II. That many of our local communities in the area had been populated by Jewish physicians fleeing Hitler, 1945, 1946. Coming to Ellis Island, where the Jewish Refugee Service had a contact with a physician in Glens Falls, a pathologist, and they would call Dr. Maslin and say, we have another one, another physician, where should we send him? Well, how about Newcomb, how about Indian Lake, how about North Creek? What about Schooner Lake? Having all come at the same time, 30 years later, they were beginning to retire, all at the same time. So what we faced was the prospect of a horrible vacuum with no local service, which I thought was a terrible, terrible disadvantage. There's nobody to help us. But it turns out because there was this prospective vacuum, everybody helped. Our local towns, our volunteers, local people, certainly our patients came together and were able to do what turned out to be only a start of something that is now, as you've just heard, much bigger. So we are here in part to thank the people of this community who made all this possible.
And you've obviously grown from those 4 health centers.
We have grown. Over the years, one town after another has come to us and asked, and the approach was, I think of Fort Edward, for example, early in this century came, the supervisor said, we're losing our last physician, Dr. Feingold. What should we do? I said, you need to talk to everybody in healthcare, and if you decide that we were a good match, come on back to us. But you might start with the town of Chester, see what they have to say. And so the invitation to those communities was really important, and then also in turn, the invitations, the approach, the calls from several physician practices who found in a changing time, so then we'll get to this, how healthcare is changing. It was simply becoming more and more difficult, verging on impossible to maintain the same kind of very small practice that they had started with, and were looking for a way to come together for new strength, new ability, new services. And so with that, we now have what we are glad to call Hudson Headwaters Health Network.
And very rural in nature.
Certainly very rural in
Demographics
nature.
very similar.
Yeah, our core area, the beginning area, is rural. One of our first 4 health centers, Indian Lake Health Center. Where is that? Hamilton County. Clearly the most rural county by any measure in the state, and probably in the east of the United States. Over time, more by accident, I suppose, serendipity, emergency support, we have evolved into 2 small cities, Glens Falls to the south, Plattsburgh to the north. But the core activity started in these rural communities.
We often hear the phrase access to care when talking about rural areas. We hear it from health officials and public health officials. Some may assume that it means there is a lack of physicians in the local area, but you say it's really much bigger than that. What does that mean in practical terms?
Yeah, access to care means a patient has a need and goes and gets care. Well, if you don't have a physician, period, in the community, that's lack of access. If that physician happens to be far away because you're in a big rural area, that's lack of access. Happy to say that we've done the numbers, run the numbers, and Hudson Headwaters, 95% of our patients are able to live within 10 miles of a health center. So that helps. But there are other reasons. Lack of insurance coverage, lack of funds to pay for the care is terrible. And especially in a rural area is a source of shame. And so without that insurance that is being covered, unwilling to accept charity, another major cause for lack of access. And in fact, also the reverse, that lack of insurance coverage is a reason for lack of physicians. That if you're in an urban area, even a smaller urban area like Glens Falls, and you're a physician and you can't afford to accept Medicaid or can't afford to accept the uninsured patients, you tell them to go to the ER. If you're in Chestertown, there's no ER, there's no place to go. And so that made medical practice financially unviable for any physician with a conscience who said, if a patient appears at my door and is sick and in trouble, I have to take care of them. And with no finances, no possibility. And it goes even deeper. What we found over time was many of our patients would not enroll in Medicaid because Medicaid sounded like charity care. It sounded like an advertisement, I'm a poor person. And I like to think more in our kind of area than in others. That's a stigma, and that's a disincentive. So access is more complicated than simply not having a doctor, but not having a doctor is tied in with all those other dynamics that go with healthcare.
And speaking of the number of doctors, in rural areas there are simply not as many primary care providers as there are in urban areas. How does that affect the residents in terms of their health?
Yeah, I would just add, and maybe just mute that, John. I'll get to that in a second, but with access too, I think one key point to make is that access has also changed over time, and today a lot of access is contingent on internet access and access to reliable transportation. And so quickly, I think we have evolved Hudson Headwaters to really try to address those issues as well, which extend far beyond the one-on-one patient interaction, which is really the foundation of who we are. So, today we do a lot of work advocating really for the region around some of the key parts that are so important around access, technology. We'll get to it later, but also bringing care to people's homes, which I think is going to become increasingly needed in places where the population is getting older. And then even very specific things that come up, like the pandemic's a good example. Access to vaccines, access to testing. So over time, we've really worked hard to evolve to meet those access needs, which have really extended beyond the one-on-one encounter. But again, at the core of who we are is really that one-on-one encounter, and I was certainly reminded of that this morning, seeing patients before heading up here, and I think finding the workforce is just critical for us, and we are really working hard to try to grow our own in that respect and train physicians through the residency program in Plattsburgh that we helped expand and with others, but certainly medical students, and then also PAs and nurse practitioners. So today we have our own training program for those folks. So we realized if we wait around for someone else to solve the workforce issue, it could be a really long wait. So we've certainly taken it on as a priority challenge and critical for our area, because without the workforce, we really will have a hard time sustaining and expanding the work that we do. And so that's an everyday project for us for sure, but I think it's worked, and we're certainly hoping to accelerate it.
Now let's talk about your locations. Hudson Headwaters currently has 21 health center locations within the region's micro cities, as John mentioned, and very small rural towns. How do you decide where to locate a health center?
Sure, I can take that. We, as John said, often, probably 9 times out of 10, folks approach us and say, hey, my community is really vulnerable. We're at risk of losing our provider. We know that if 1 or 2 of our providers or caregivers in the town get sick, that we have a real big problem. So that happens very frequently, and then also I think we've been spending a lot more time looking at data and trying to figure out where in the Adirondacks and surrounding communities are some of the worst outcomes, and who are the populations most in need. And now there's data that really helps us identify that. And so we're trying to be more scientific about where to go next. There's sort of an abundance of opportunity in almost every direction because of the complexities of the work that we do, and we are a strong, growing organization, so lots of opportunities. But I also think that trying to identify the most vulnerable populations is probably our biggest priority right now, and the mobile unit, which we'll talk about in a few minutes, is really designed to take the high-level care that we provide to some of the most remote areas and some of the groups of people that have really not been able to get to care. And the goal is to find those folks and engage them, try to keep them out of the hospital settings, the nursing homes, But to do that, we're going to need some special tools, and the mobile unit's a great example of that. So it's a little bit of science and a lot of listening to the people we serve and the communities that we are in, and those that we recognize need help.
And I was going to ask you about that. That's a great follow-up. Who are the hard-to-reach patients in the region, and how do you find these groups and address their needs?
Yeah, maybe Dr. Rugge can talk about our Homeward Bound program, because that was sort of the beginning of a lot of some of the work that we've come back to.
From the very beginning, home care is key. And actually doing house calls was kind of easy in a way, because our physicians mostly lived in the Glens Falls area and drove to their health centers. And stopping along the way to do a house call kind of came naturally. And on several levels this worked. I mean, one is just the appreciation and the memories that people have for a doctor making a visit. My personal experience, I remember Dr. Burke. I remember Dr. Burke making a house call on my mother when I was 10 years old. And I think for a region like this, and another question coming up, I'm sure, is how do you attract physicians? Attract physicians in part by those physicians knowing they're making a real difference. They know their patients. They know how important they are. And an extension of that is organizationally, how do we find those patients most in need? And again, another dimension of all this is we talked about public support, community support, but also public funding at the state and federal level. And the concerns there of the Community Health Center program is how to reach those most difficult to serve, how to do what no one else can do except with that extra support. So if you will, we are incentivized to find those people who are going to go without if we don't care for them. And so there's again, this synergism of wanting to do good, of being rewarded for doing well, and a little bit outside the usual paradigm of capitalistic medicine. This is a community health center, and the support we have it can't be overstated.
And Dr. Slingerland, you were talking about, and I think they've seen it on the screen behind us, the beautiful new mobile health unit. It truly is a health center on wheels that you can now go to communities.
Yeah, so that's something we just literally took on the road a few months ago to Salem, which is in Washington County, very rural setting, and lots of very generous contributions from foundations and businesses in the community to help us get this launched, because the startup cost definitely significant, but we really view this as taking the exam room closer to people. And I helped plan this for a few years, but it became really real the morning a few weeks ago when I saw patients in the mobile unit. And the space has got the best technology I think that you can find anywhere. It really feels like an exam room in one of our health centers. And very quickly realized that the patients coming were people that were on really long waiting lists to establish other places. People who, I saw a patient with an acute asthma issue who certainly would have ended up in the emergency room. So we, like some of our urgent care settings, we were there at the right time for those folks, and they've become part of the network. And the plan is to really get this up and running in the southern half of Hudson Headwaters, but then with the second unit to deploy that in this direction, and really trying to identify the right towns and communities to take the mobile unit to is something we're working hard on. And there's all sorts of issues figuring out the water supply and the electricity and the internet connection, and in some places we may need a satellite connection to really make it all work, but the team at the network has really thrived at that challenge. And I think the learning curve's steep because there's not a good manual for how to do this, but I think it's a great tool. And as you know, in the Adirondacks, there's often a lot of distance between people's residence and where the provider lives. So trying to figure out how to adapt to that. Telehealth video encounters was something we had talked about for a long time, but the pandemic really accelerated and brought us into the homes of countless patients. So that was a really good addition, especially for mental health needs, we found. And we also have a Homeward Bound program that we have a group of patients who are really that are sort of so sick that coming to the health center is hard. So we've been sending providers out for a long time now to do that care in their home. So I think more and more we'll be evolving towards trying to figure out how to get closer to patients. And it might not always involve a really big health center, even a small one, but the better use of technology and new resources like the mobile unit.
Tucker's response makes me aware that I only half answered your question, Thom, about how do we do this with house calls and all the rest. So for a time we do it on the fly. Dr. Way is driving from Glens Falls to Indian Lake, see the person in Sodom on the way. But as we get bigger, there's more need and more patients, and how do you do it, because you simply can't schedule that 8 o'clock p.m. visit all the time and all the rest. So that led, as the years went by, as we grew, more doctors, more PAs, more nurse practitioners, certainly more patients, to say, we've got to organize this, and created something we came to call the Homeward Bound program, where we have dedicated staff, a medical director and Dr. Blood, who spends part of her time directing and doing the house calls. PAs and nurse practitioners who do house calls, that is their profession. And so now we have something on the order of 600 or 700 patients, too sick to move out of their home, but able to stay at home because we can be there, providing the medical care they need. That we can, in COVID times, bring them the vaccine that they need so they are protected, even though they can't come to get it. So, what we found was growing from one center to 21 meant we could do more for those same people because there were more staff, more ability, more agility, and the variety of interest. I mean, I like to think and I like to say that as new physicians join us, we're asking them, what can you add to us? This is not simply coming and joining the assembly line. What skills do you have? What background do you have of doing something we've not thought of yet or had the time for? And that's the way we both attract and retrain these people, because it really becomes their practice, even though it's in the context of one with dozens and now approaching hundreds of staff.
That's incredible, 600 to 700 homeward bound patients.
Yes.
Yeah, I would just add that diversity in job description does drive some people a little crazy, like our HR folks, because all of us have slightly different jobs, and we're always thinking of new initiatives and things to try out, and so that's become sort of part of our genetics and work that we're really comfortable with, and it's got its own energy related to innovation. And that's been inspiring as a recruitment tool, but also for keeping people with the network.
And I imagine many of the patients who are part of the Homeward Bound program may be elderly. And we know that there is an aging population in the Adirondacks. What challenges go with that for you folks?
Who's up?
Yeah, I'll try. So yeah, certainly we're seeing more very complicated chronic conditions. And occasionally we'll see people with a head cold or an earache, but more and more the day-to-day work we do has multiple layers of overlapping chronic conditions that really need close attention and coordination with our hospital partners. So I think we're probably going to see a lot more of that. And now more than ever, people are under a lot of stress, family stress, mental health stress, work stress. So we have that layered in, and so that I think the care has certainly it feels like it's gotten more complicated, in part because the population's getting older, but also there's an awful lot going on these days, and that's reflective in people's health. And so we're doing everything we can to anticipate that. We have a program we're launching in 2023 called, it's a PACE program. It's a program for all-inclusive care for the elderly, but really an alternative for people to stay at home but get really intensive medical attention so that they can stay home a whole lot longer than going to a nursing home. So we're going to try that in Glens Falls, but hope to scale it across the region when we get the model down. And so it's exciting. But that's an initiative that we picked out of kind of a menu of opportunities, but did so recognizing that the population was going to get older and really need those kind of services.
This also reflects our community. We are, in this region, the Adirondacks are second only to Southwest Florida for having people over the age of 65. And so if you're going to meet community need, you're going to take care of people who are dealing with aging. And there's close to 2,000 community health center corporations, something more like 10,000 health center sites around the nation. And my understanding is we have more Medicare patients than any of those health centers because of where we are, who we are.
Let's talk for a few moments about COVID. What impact has COVID had on the Adirondacks and on the communities you serve, and how has Hudson Headwaters responded to the pandemic, both early on dealing with the outbreak and then now in more recent months getting people vaccinated?
Yeah, this was an unexpected chapter, but I think regionally we do have a lot to be proud of. I think in partnership with the hospital folks and also public health, really have done the best we can vaccinating and testing folks. Hudson Headwaters in particular, we've done over 100,000 tests and delivered over 30,000 vaccines, which was quite a task for us to figure out how to, everything from transporting vaccines to, who can get it. And the public health infrastructure really needed close partnership, so we were able to do that. The hospitals were good partners in this as well. It certainly feels that we're not entirely out of the woods yet, and we're watching this very closely and trying to be very safe as much as we can, and still trying to convince as many people as possible to get vaccines, which I think is the real work. And even if we only get a few a day across the network, we're happy with that. And it definitely also accelerated things like telehealth. Use of the video encounters, phone encounters, really integrating that technology into our workflows, super important. And then also defining all sorts of things related to work environments. And today we still have a large group of employees at Hudson Headwaters that pretty much work from home, and they're doing great work, and that's worked out really well for us as an employer. But we also know that it changes by the day, and our Chief Medical Officer, Dr. Borges, has become a bit of an expert following this, so we really look to him for good guidance and coordination with the hospital partners, public health.
Also, I think COVID is one more example of how doing healthcare shows community need. That how, as Tucker hinted at, we went from doing a dozen or so telehealth visits in a week to doing thousands within 3 weeks. And we're able to make that move. But how odd it is for a telehealth visit or a telehealth visit. At times we were telling our patients, you need to leave the house and go to the town hall parking lot so you can get broadband so we can do our visit together. Rural electrification came a number of decades ago. Broadband is the same kind of thing. There's a need, and we can see that need, and all together, we can advocate for it.
Like so many things with COVID, you mentioned people working at home. telehealth is something you see continuing, that a lot of people will continue to utilize that even after COVID.
Yeah, today it's integrated in with our regular encounters and really feel that it's here to stay. But again, it only works if you have an internet connection, if you have a computer, and there's big inequities there that really need to be addressed. And we did partner with one of our providers to bring that technology to some of our parking lots, and found that patients really made use of that, including kids who needed to get internet access for school. So, again, we're realizing that a lot of this work extends beyond just the day-to-day patient care that we do in an office visit. We really got to get involved in these issues and really advocate for them, because it will be a big part of the future, and we're also finding new applications for it. Behavioral health counseling through telehealth, really, really important, especially when regionally, nationally, we don't have enough counselors and psychiatrists. So, how can we use the technology to bring some of those resources to people in remote areas? So we're doing a lot of work around that, and it definitely feels like it's here to stay.
You've mentioned we're touching on technology. You folks do a lot of out-of-the-box thinking about other ways that you can reach and serve your patient base, programs to try to reach those hard-to-reach patients.
Just have to say, it may not be intuitively obvious until it's explained, that behavioral health is one area in which telehealth turns out to be extra important, not only during COVID, but probably will be a continuing phase for a number of reasons. It's easy, it's private. You don't go to the waiting room and be embarrassed about what kind of problems you're presenting. It's confidential. And it's the one kind of medical encounter that doesn't require a physical exam. Seeing somebody face to face and hearing the story and responding to it works. And again, that's another good example, I guess, of how Hudson Headwaters has adapted, modified, changed, and evolved over the years. Initially, we had no behavioral health services, nothing we could afford, nothing we could do. As we got bigger, it becomes clear every patient has a psyche, and some of those are troubled, and they need support. And remember, the very first time we hired a nurse practitioner was because I had a 1-year state grant, and pulling a very proficient nurse practitioner from St. Peter's Hospital in Albany to Warrensburg for a year seemed chancy. As it turns out, that state grant expired, but in that very year, the federal government in our program had a competition for money for psychiatric care. And we won that competition because we were already doing it. So again, the layering of one level of support to another, and taking advantage of those serendipitous chances means everything. And so now we can't imagine doing primary care without a behavioral health component.
And you've talked about growth. Since its establishment 40 years ago, Hudson Headwaters has not only grown but flourished. What sets you apart from other healthcare providers? What can other rural providers learn from your success?
Well, it's interesting. I mean, a key point is we don't expect and wouldn't want everybody to try to be exactly like us. That we feel that those physicians in private practice in their communities, Plattsburgh and Glens Falls especially, those people in other kinds of group settings or working for hospitals are our friends and our colleagues. We learn from them and they from us. So we're not, we have no reason to be arrogant to say this is it, this is the way to do it. By the same token, everything I've described already and Tucker's described as well, community support translated into free housing. Our health centers are provided to us free of charge. Means we can afford to give those discounts and not expect payment for somebody who really can't afford to pay it. That translates into likewise state and federal support, not only monetary, but trying things out. If there's an experimental program, something they're doing for the first time, we have a track record that they now can come to look to us to say, why don't we try it at Hudson Headwaters? We know they've succeeded with other programs and are flexible and committed. So I think those are key attributes. We don't expect everybody to be exactly like us, but we're glad also to be here and do some things that would be very difficult to do except for the peculiarities of our history, our background, and that very broad-based support.
Yeah, I think it also has to do with just a deep sense of service. And we absolutely believe that we exist to serve the communities that we're in. And I think the people that we attract believe that for sure. And we have opportunities every day to really improve the lives of other people, to really try to help our patients live in a way that they can make the most of every day. And we're a group of folks really working hard to problem solve and provide that service. I think we also really value the relationships that we have with the other providers in the communities that we're in, including private practices, hospitals, all sorts of other organizations, and enjoy the exchange with them and the problem solving and the relationship building that happens. Also, all of us live in the communities that we serve or nearby. We also really value the resource and the opportunity that this region represents. So it's a way for us to take care of our neighbors and to strengthen the places that we love and want to be in. So it's really satisfying work, but it really comes down to service, and I think also relationships. The relationships that I feel like I have with patients, the one-on-one encounters, that is the grounding element probably for the network, and you get to know entire families and all sorts of overlaps, and that's a real privilege. But with that is a responsibility to do the best that we can, and we're not perfect. We certainly make mistakes, but we try every day to do the best that we can. And that includes the one-on-one relationships, but also these broader ones that John mentioned with the state of New York, with the federal government, with the hospital partners. So it's a privilege to do this work.
Another story. I remember in the early years thinking it was such a disadvantage. We really couldn't come up to the same economic standards for physician compensation that was the norm. We were below. And how difficult that was and how regretful. And then we came to 2007 and had some setbacks in terms of reimbursement changes and the rest, and had to impose a 5 or 10% reduction in salary, give back. Not a single physician, not a single provider left. And it became clear they weren't here because they made more money here. They came for other reasons. Came because, they could make a living and they could send their kids to college, even to medical school. But we don't talk about it as mission, but talk about it as the life you live, the people you get to know, the people that come to depend on you, and how much that's a reason for being here, for serving. And the feedback and all the ways we've been describing by way of town support and advisory committees and all the rest is the fabric of Hudson Headwaters.
Let's talk about recruitment and healthcare education, as they seem to go hand in hand at Hudson Headwaters. This year, Hudson Headwaters has recruited many providers, often a challenge for rural healthcare organizations. Tell me about recruitment and about the education opportunities that you provide.
So I can start with that. Recruitment is a daily activity for us at Hudson Headwaters, and I think fortunately we live in an amazing region. So finding folks that really like outdoor activities, who have spouses that like outdoor activities, who have ties to this area, really seem to be the the real sweet spot for us. We spend a lot of time working with medical students and even some high school students to get them really thinking about careers in healthcare. We definitely have some partnerships, University of Vermont Health Network in Burlington and then Albany Med, to try to encourage medical students to spend time with us. We've been doing medical students, having them come to Hudson Headwaters for several decades from Albany Med, and but also other students from across the region that have interest in healthcare. But I think more and more, a lot of it comes down to helping train medical residents, so folks who are physicians made that commitment to do primary care, really helping to attract those folks to the network. So in Plattsburgh, CVPH launched a family medicine residency program. We have helped them expand that. The first graduating class, we hired 3 of the 4 graduates. So that's been a great source of new physicians for us. But half our network is PAs, nurse practitioners, and midwives. So in the last 2 years, we've launched a training program for those folks as well, where we really continue their training upon graduation from their programs, and that's attracted a whole nother group of people that we think are going to be really outstanding. And so we're always looking for and trying to advocate for more opportunities, especially for kids from the North Country that have interest in healthcare. I think that's something we can do with the deans of the medical schools and with the nursing programs to really try to advocate for those kids that are interested in healthcare to help ensure that they have the opportunity, and that will be an ongoing work task for many years, I think, to come.
I think also part of the paradigm is to say to a physician, there's a lot to healthcare, and much of it, maybe most of it, is seeing patients one by one, but it's also organizing services, providing leadership. And our physicians do that. So one distinction early on was most medical practices, hospitals, would have a really well-trained administrator recruiting. For us, it was a physician making those calls and explaining what we do, and the realization being that physicians do those extra things, those extra activities, and enjoy them and get satisfaction from them. And that kind of initial approach helps explain, if you have a special interest, we'll put you where you can pursue that interest and do more than you could elsewhere. So that became the basis for competition. It wasn't you can make more money here, is you can do more things here.
And we've touched on this a little bit, but what can other rural regions learn from the Hudson Headwaters model of providing rural care?
We like to think they've already been learning. That when we first applied for our first federal grant back in 1978, we had 4 health centers. Almost no other health center program had more than 1 site. Now the average number of all health centers across the nation is 6. When it comes to treating the Medicare, the older population, HRSA, the Health Resources and Service Administration, part of federal government that is interested in this kind of health care, understands that we have more Medicare patients than any other health center in the nation, and look to us to what can we do by way of us meeting a special need or creating a special program. And so, you know, again, not to just snap suspenders, but to say we enjoy those contacts because we learn from those other programs as well, and it's having that kind of interaction and the advantage of some scale, so that we cover a good part of the Adirondacks now, but then also we can reach out to others across the nation who are trying to do services as we are, learn from them and vice versa. And it's a huge help. And it's also a source of recruiting. Sometimes these people want to come to us. We have the Adirondacks after all.
Dr. Rugge, Dr. Slingerland, thank you very much for talking with us. We are going to open it up to the audience now.
Thank you. I'm Robin DeArmas. I'm a retired physician and live in Indian Lake. My practice in Florida before I moved up here was radiology practice. I know you have partners, and you're partners with the hospitals and radiology groups and such as that. And this idea of your mobile center is a great idea. Are there any plans for mobile imaging types of things to be done with your radiology partners or whatever else? The people in Indian Lake, you know, the doctor sees them, and the next move is down to Glens Falls for a CT scan or down for a MRI or something like that.
Yeah, great point. I think we would love this to be a mobile caravan to include a lot of other services. I think, the exciting thing is a lot of this technology, as you know, is getting smaller. So I think, in the near future, a bunch of this technology will be smaller, more mobile. We have been spending a significant amount of time in the last few years training providers in handheld ultrasound, which is a kind of a growing field, and it's not anywhere at the level of a real, big ultrasound machine, but it is awfully handy in the hands of, someone that's done it enough to know what they're looking at. But the learning curve is steep on that as well. So, we have looked to our private practice radiology partners, but also hospital partners to meet that need. And but you're right, getting those services into the smaller communities should definitely be a priority, and figuring out how to do that. And I think there is a mobile solution. We're just not quite there yet. And I was super happy to see, though, when I was in the mobile unit, that I needed an EKG, which worked great in the mobile unit. I needed COVID testing done in the mobile unit, which happened point of care, which was pretty remarkable. So I think that is in the future for us, but we're not quite there yet.
We'll say when it comes to imaging, there is no better example of how healthcare has changed. When we started, we had an X-ray unit at the Chester Health Center, and the X-ray technician would click the switch, take the film, and then develop the film and the solution, and then send it later in the day or the next day down to Glens Falls for reading by the radiologist. And so in 2 or 3 days, we would have a report back. Now the image is electronically sent at the speed of 186,000 miles per second to our radiologist, and if we wanted a reading right away, we simply call up and say, Bill or Bob, can you please take a look at this right away and tell me what you see? So it's a huge addition in terms of improving the speed, but also the quality of care for a rural area.
One remarkable thing, I think you told me that when you finished residency, the CT scan was just appearing, and so that's pretty remarkable. And then for me, I joined Hudson, I don't know, 11 or 12 years ago, and for the first couple of years, we were using paper charts, which are now, non-existent. And the physicians and APCs that we're hiring have never used a paper chart. So it's, healthcare is changing by the moment, and we're expecting to see all sorts of interesting technology.
This speaks to age, but only after I started practice did Glens Falls Hospital get its first CAT scanner. And Saratoga was not allowed to have one because the state said you're too close to Albany and you won't pass a certificate of need test. So the dispersion of medical services, technical services, is radical. And another surprise to me, just last week, we were celebrating another anniversary of one of our physicians, Dr. Racine in Champlain. And I see that at our Champlain Health Center, we are now inserting insulin pumps on site. Don't have to go anywhere else. You simply get it at the health center, So for type 1 diabetes mellitus, you get the insulin you need and the dose you need automatically. Huge changes, and so more and more care is migrating out of hospitals into health centers, and also out of health centers into the homes. And we're trying to be in all those places.
Thank you for your question. We'll come to you, yes.
My name is Betsy Hirschman. This is my husband, Don.
Hi.
We live in Blue Mountain Lake 4 months out of the year. We live in South Florida the rest. I don't know how you work. As I look at this little tiny building in Indian Lake, and I see this great big building in Warrensburg, and I don't know how are they staffed? What type of people are in them? Do you only do family medicine? Do you do specialists? You talk about hospital partners. Who are they? How do they work? Do you have staffing privileges in them? So if I get sick and I go to Indian Lake, is there going to be somebody there to see me? Do I have to make an appointment? Does the person, I understand they're maybe there a couple of times a week and somebody travels around. Is it a doctor? Is it a nurse practitioner? What is in that big building in Warrensburg? So practically speaking, I don't understand at all how you operate.
Let's start in Indian Lake, close to Blue Mountain. From the beginning that we started in that center in 1978, we had a team. We had physicians and PAs working together, sometimes together in the center, sometimes a PA in the center, and other times a doctor in the center, just in terms of how history works. One of our initial board members, our board of trustees, turns out to have been an EMT, emergency medical technician, a fellow named Thom Warrington, lived in Blue Mountain Lake. He decided, on the strength of his exposure to Hudson Headwaters, maybe I should become a PA. Went to PA school, graduated, spent his entire career at Hudson Headwaters with Indian Lake being his home health center. Dr. Way, who grew up or had family in Glens Falls, was the grandnephew of Seneca Ray Stoddard, the photographer from the 19th century, decided he really loved being in Indian Lake as well as North Creek, because on the way he could take all those photographs, just like his great uncle, and make a name in books for himself, which he did. So it's basically a team approach of finding people who have deep community roots, have an interest in who we are in a very special way, and working together as a team. As we evolved and Warrensburg opened, realized that in Warrensburg there was, number one, a little bigger population even in town. There's 4,000 instead of 1,500. But in addition, if you're going to go anywhere south from Indian Lake or Chestertown or Schroon Lake or North Creek or Sodom, you're going to go through Warrensburg. And so Warrensburg Health Center is two things. It's primary care for all those local people, about half of the people in Lake George, people in Thurman, people in Warrensburg. And in addition to that is specialty care for all those and all those farther north in the fan. And so we can provide the imaging services, whether it be a mammogram, an ultrasound, or an x-ray. We can provide specialty services where specialists come because they can come from Glens Falls or even farther south to Warrensburg because they know there's enough patients there to warrant their day. And so the population for specialty services in Warrensburg is about 25,000. You can do things with 25,000 people you can't do if you're only 1,500. But we're trying to do everything we can as close to home as possible. So that's essentially how we operate, with one center backing up another. So urgent care is also provided at Warrensburg 7 days a week, 12 hours a day, except Sunday's only 8. And patients can go there, at least it's within the blue line. It's still within our community of service. So everything that we can do that's feasible, we try to do.
Yeah, I would just add in Warrensburg, we also have neurology, mental health services, pediatrics, orthopedics, nephrology, vascular surgery, cardiology, and a dental practice. So, and that's part of the challenge, is helping people understand Hudson Headwaters, and it's not just, we define primary care very broadly. I didn't even mention the women's health services that we have there. So, that's part of what we try to do every day, is convey that it is broadly defined. Basically, almost anything that doesn't involve an operating room. But that's a constant communication element that we work on, and in urgent care there, proved to be really handy during COVID, because with the extra space there in the parking lot, that was one of the first places that I remember I was an urgent care provider on the 16th of March when we sort of realized that we had a real problem, and that was the first place that we sort of tested out triaging people in the ambulance bay and how to keep staff safe. So it's a big building. There's a lot in there, and we definitely have more work to do to help the public understand what that represents.
Thank you for your question. Yes, sir.
I'm Don Hirschman. I have a question. I'm curious, what percentage of your budget, your financial budget, is dependent upon federal and/or state funds?
What would you say?
Depends how you count it. I mean, most community health centers have about 25% of their budget based on the federal grant. For us, it's about 4%. And it's 4% because most of our patients are paying patients. Most have Medicare, have Blue Cross or whatever. So we take care of the entire community. We're not a poor people's clinic. We take care of people of all kinds. By the same token, primary care in America is disastrously underfunded. And standard fees for service means a physician, if he wants to send his child to college, sure can't see a Medicaid patient. Pay is too low. Sure can't see all that many Medicare patients even because pay is too low. We serve everybody, and it's because we have also robust community public support in other ways. If we're doing a new venture, almost everyone is started with a state or a federal grant to either build a new building or launch a new service. And so it's difficult to define X percent or whatever, but fee-for-service medicine only accounts for hardly more than half of everything we need to do and are able to do because of all those other kinds of support.
Yeah, I think the other way to look at it is we definitely treat all comers. So we have people with, very high-end commercial insurance. We have people who run their own business and pay directly for their care. We have a whole group of patients who can't afford to really pay anything, but we have the luxury of not, as a provider, ever having to turn anybody away, and can see everybody independent of how that bill is paid, and that translates also into prescription assistance. So the medications we prescribe are expensive, and because of our size, we have good systems to help people cover medications who otherwise would go without. And the grant, John, the grant work that we do is pretty significant as well. We heavily rely on grants and from all sorts of sources that really support many of the newer programs that we do and things that really have no funding otherwise.
For the decades that I was seeing patients as well as doing the administrative stuff, I was proud of the fact that seeing patients, I never had to look at what kind of insurance they had. I gave the same care to all my patients. The only time when I was aware of that is if I had to refer to a specialist, maybe that specialist didn't take Medicaid or non-paying or whatever. But otherwise, it's the same for everybody, but we're only able to do that in this fractured American system of healthcare payment by looking at innovation and looking at the next source of funding, be it public or being private. The mobile van came about from a local private foundation that was looking at over a 3-year period, committing $1 million for healthcare. There were a number of applicants. Hudson Headwaters applied saying we would really like a mobile van, but it's going to cost $1 million. That entire grant came to Hudson Headwaters in recognition of what we could do, but also recognition of what we've been able to do in the past. So that's the kind of legacy that we depend upon and the kind of future we hope to build.
Excellent. Folks, we said we would keep it to about an hour, so we'll take one more question if that's okay. And yes.
A bunch of us here are on the borderline. Some of us would go toward Utica, Rome for our health care, and otherwise we would be going to Glens Falls. Maybe if we want to, we could go run up to Saranac Lake. Being on the borderline and being a low population area, we're between a rock and a hard place. What would it take, or how would we go about getting Hudson Headwaters to come a little bit further west into the heart of the lost Adirondacks? From Rocket Lake, New York, I speak.
We know you're working on it.
Yeah?
and you know, conversations began thanks to a veteran on one of our boards, Thom in Old Forge, years ago. And I can only say that rather than lack of interest or that can't be done, we just know these things really do take time and community effort over time. And sometimes serendipity happens, and in a flash of a few months things happen, but typically it's a matter of preparing over years. And I can say on behalf of Tucker that for sure we've got a good working relationship with our hospitals, and if we go farther west, we'll have a good relationship with hospitals in Utica, and depend on that. And we want to have that. So we're here to grow, and we hope to do that.
Thank you.
Thank you.
Gentlemen, thank you. Dr. Rugge, Dr. Slingerland, thank you for taking the time. Thank you folks for coming tonight. We appreciate it.